Welcome to the deep dive. Today we're zeroing in on chondrosarcoma for your MSRA revision.
That's right.
We're using chondrosarcoma, a concise overview, as our main source material.
Hmm.
And the mission really is to pull out all the key high-yield info you need to know. So let's get straight into it.
Okay, so chondrosarcoma, what is it? Well, it's a malignant tumor, comes from cartilage cells.
Malignant cartilage cells, okay.
And it's actually the second most common primary bone tumor in adults.
Second most common. Where does it typically show up?
You usually find it in the pelvis, the femur, and the humerus, those big bones.
Right. Pelvis, femur, humerus.
And a really key characteristic, the tumor cells themselves actually produce cartilage matrix. Remember the stuff cartilage is made of.
So they make their own matrix. Got it. Okay, malignant adults, those locations makes matrix. What actually causes it? Do we know?
Well, the exact cause. It's still a bit fuzzy, to be honest. It's under investigation.
Okay.
But we do see certain associations. There are links.
What sort of things?
We see it more often in people with specific genetic conditions like hereditary multiple exostoses or Ollier's disease.
Right, those cartilaginous conditions.
Exactly.
Yeah.
Also, previous radiation exposure seems to be a factor sometimes, and certain chromosomal abnormalities too.
So no single trigger, but definitely some risk factors. Is there an easy way for, our listeners to remember those?
We could try a mnemonic. How about HORC?
HORC. Okay, break that down.
H for history of those hereditary conditions we mentioned. O for older age, it's more common as people get older. R for radiation history. And C for those chromosomal abnormalities.
HORC, history, older age, radiation, chromosomal. That's actually quite helpful, thanks.
No problem.
So going a bit deeper, pathophysiology, what's happening at the cellular level?
So basically, it starts with genetic changes in those cartilage cells. Something goes wrong, and they start growing uncontrollably.
Uncontrolled growth, okay.
And we know some specific gene mutations are often involved. You might see mentions of IDH1 and IDH2.
Ah, yes, IDH1 and 2. I've heard of those.
Yeah, they're involved in cell metabolism. Disruptions there seem to push things towards tumor growth. But the exact step-by-step process, that's still being researched pretty actively.
Understood. Genetic changes, IDH12 often involved, but details still emerging. Now, differential diagnosis. If you suspect chondrosarcoma, what else needs to be on your radar?
Oh, that's crucial. You absolutely have to differentiate it. Key things to consider. Well, other bone tumors, obviously, like osteosarcoma.
Right, the most common one.
Yeah. And also benign cartilage tumors, like enchondroma. You need to tell them apart.
Benign versus malignant. Makes sense.
And don't forget metastatic cancer to the bone. That can look similar sometimes. Plus other rarer cartilaginous lesions.
Okay, so quite a few mimics to rule out. What about the epidemiology? How common is this, say, in the UK?
It's considered a rare cancer in the UK. Makes up only a small fraction of all bone tumors.
Rare, okay. And age group?
It's mainly an adult cancer. The peak incidence is generally between 40 and 60 years old.
Middle age, mostly. Any gender difference?
Slightly more common in males, but only slightly.
Okay. Rare, 40-60 picks, slightly more males. How do patients typically present? What symptoms should make you think of it?
It can be quite varied. Depends a bit on location and size. But the common things are localized pain, often deep, aching pain, swelling in the area too, and maybe some tenderness if you press on it.
Pain, swelling, tenderness.
Yeah, maybe think LPS. Localized pain, swelling, helps remember it.
LPS, good one.
And as the tumor gets bigger, it can cause other problems, bone deformities, maybe even a pathological fracture.
Right.
Or it could press on nerves or other structures nearby, compressive symptoms. But, important point, sometimes it causes no symptoms at all.
Really? Asymptomatic?
Yeah, it might just be picked up instantly on an X-ray or scan done for something else entirely.
Wow, okay. LPS for the main symptoms, but can be silent. So if you do suspect it based on symptoms or imaging, what are the investigations? How do you confirm?
Imaging is absolutely central. You'll usually start with X-rays.
X-rays first.
Then probably CT and definitely MRI. They give you much more detail on the tumor size, exactly where it is, how far it extends, relationship to other structures.
See the details. But how do you know it's chondrosarcoma?
For the definitive diagnosis, you need tissue. So a biopsy is essential.
The biopsy.
That confirms it's actually chondrosarcoma. And crucially, it allows for grading. Determining the grade is vital for management and prognosis.
Grading is key. Any other tests?
You might do some blood tests, maybe a bone scan or other imaging like a chest CT, mainly to check if it has spread anywhere else, staging.
Okay. Imaging, then biopsy for confirmation and grading. Got it. What about management? How is it treated?
The absolute mainstay of treatment is surgery, surgical resection.
Cut it out.
Essentially, yes. Wide local excision, aiming to get the whole tumor out with a margin of healthy tissue.
Right.
The extent of the surgery really depends on the tumor's grade, size, and location.
Right. What about radiation?
Radiation therapy. It has a role sometimes, maybe as an adjuvant treatment after surgery in certain cases, like if the margins weren't clear, or for higher grade tumors, sometimes for unresectable tumors too.
Okay, so surgery first, radiation sometimes, chemotherapy.
Generally, chondrosarcoma is resistant to chemotherapy, so it's not usually part of the standard treatment
Well,
plan.
good to know. Chemo usually ineffective. And
Uh,
follow-up?
Oh, absolutely vital. Regular follow-up with imaging is needed to watch closely for any signs of recurrence.
Makes sense. So prognosis. What influences the likely outcome for a patient?
Several big factors. Tumor grade is probably the most important one.
The grade again?
Yes. Low-grade tumors generally have a much better prognosis than high-grade ones. Much less likely to metastasize.
Lower grade, better outlook.
Definitely.
Yeah.
Other key factors are the stage of the tumor, has it spread, and whether the surgical resection was complete. Getting clearer margins is really important.
Complete resection matters.
Hugely. Also, the presence of metastasis significantly worsens the prognosis. Local recurrence is a known issue. It can happen even years later, especially with lower-grade tumors that maybe weren't completely removed. Metastasis is more of a risk with the high-grade types.
Okay. And what complications can arise, either from the tumor or the treatment?
Well, the main ones we worry about are local recurrence, as we said, and metastasis.
Where does it tend to metastasize?
The lungs are the most common site for metastasis from chondrosarcoma.
Lungs. Okay.
Other issues can include functional impairment, depending on where the tumor was and
Yeah.
what surgery is needed. Pain can be ongoing, and if radiation was used, there can be side effects from that too.
So supportive care must be important.
Absolutely. Rehabilitation, physiotherapy, pain management, psychological support, all really crucial for managing complications and maintaining quality of life.
Right. We've covered a huge amount there. Really useful for revision. The definition, the causes and risk factors, remember HORC.
Pathophysiology with IDH1 and 2, those key differentials. The UK picture, how it presents, remember LPS.
Investigations focusing on imaging and biopsy for grading, management primarily being surgery, prognosis heavily linked to grade and resection.
And finally, the complications like recurrence and mets, often to the lungs.
A really solid overview.
Yeah, and perhaps a final thought for you revising. Really consider how that variable clinical presentation, from incidental finding to painful mass, and the absolute importance of accurate grading, how those two things directly influence the entire management pathway and the patient's overall journey.
That's a great point to reflect on. Essential stuff for the MSRA. Now, if you want more revision resources, don't forget to check out passmsra.com.
And freemsra.com as well. Loads of useful material there.
Brilliant. Thanks, everyone, for tuning in to this deep dive.